In the late 1990s, the United States saw a sharp increase in the number of opioid overdose deaths, rising by nearly 600% between 1999 and 2017, according to data provided by the CDC. It has appropriately been labeled an epidemic, and in 2018, the country's life expectancy dropped for the third consecutive year, reflecting the ongoing drug crisis and rising suicide rates. As researchers and clinicians continue to examine the quality of different approaches to treatment, many seeking recovery have taken matters into their own hands. Our guest today, School of Interactive Computing Ph.D. student Stevie Chancellor, will present a paper on this subject next week at the ACM Conference on Human Factors and Computing Systems in Glasgow, Scotland, also known as CHI. What exactly do these addiction support communities entail? What alternative strategies are people pursuing in recovery, and why? How can we ensure that clinicians are well informed about the types of self-treatments being used outside of their care? I'm Ayanna Howard, chair of Georgia Tech School of Interactive Computing, and this is the Interaction Hour. Stevie Chancellor is an ICPH student in the Social Dynamics and Wellbeing Lab. She's advised by Mumu Deshadri, 2018 Foley Scholar, and she will be defending in June. She also has had a SNAP Fellowship, has been recognized in terms of finalists in a number of competitions. I am so pleased to have you join us. Thank you.
Thank you so much. I'm really excited to chat.
So you've done this research in social media and dangerous or deviant mental health behaviors. Now at CHI, you are presenting work on these Reddit groups that are broadly intended to support people through opioid addiction. How did you learn about these communities, and what was it that interested you and told you that this was something you wanted to even dive into and examine?
Yeah, it's a really great question. I think a lot of people at Georgia Tech get excited about solving problems. And I saw a lot of news reports about the opioid crisis emerging in the US and people using alternative substances to help them recover from opioid addiction. The biggest one that sort of gotten the most press coverage has been kratom. So I got excited and was like, wow, there must be these online communities around this. And so I started diving in and looking to see how people were facilitating their own recovery from opioid addiction.
So you found these groups like Reddit and what's happening, and you found that these members often share strategies that, well, you may not fit them into traditional clinical approaches. It's not like looking at WebMD. And so let's ask, what would these traditional approaches actually be?
Yeah, so if you're trying to recover from opioid addiction, or what would be called opioid use disorder, sort of the formal way that we talk about it with doctors, you'd be going and engaging with the doctor to get treatment like methadone or Suboxone. Those are the most common substitutes for stronger opioids like heroin or fentanyl. But you might also enter inpatient recovery, a halfway house. Some people even will try to go cold turkey, though that can be a little risky. You get pretty sick when you try and recover without the assistance of a doctor. And these have different levels of effectiveness depending on, your ability to engage with the treatment as well as your access to clinical care.
So I'm trying to wrap my head around this. So, what my grandma had told me, right? I mean, usually we take these things with a grain of salt, but there seems to be this sharing of information and people are listening. It just baffles me. So did this surprise you, or what else did surprise you? Because this surprises me.
Right. So it was actually really interesting to us because doctors know that there's a lot of barriers to getting into recovery. So there's a lot of shame and stigma associated with admitting that you have an addiction, but also there's shame and stigma in receiving treatment. People who go into Narcotics Anonymous or are using methadone are often considered junkies. They're shamed by their friends and their family, and it can be really embarrassing to have to go to the single place in your clinic every 3 days to get your methadone supply. And so when we saw that people were coming up with these alternatives to traditional clinical care, we were not surprised at the fact that they were trying to get around this shame and stigma. We were surprised at the variety of substances that they were trying. So it wasn't just methadone that they had sort of gotten off label, but other substances as well.
For example?
So kratom is the most famous one, famous relatively speaking. There's been some news reports about the FDA regulating kratom because it's sort of in this gray area of legality within the U.S. And there were some issues with contamination of kratom supplies with salmonella. But in addition to kratom, there are substances like Imodium or loperamide, what people will commonly use for gastrointestinal issues. Taken at high enough doses, it's actually an opioid. There's also use of benzodiazepines like Xanax to help alleviate some of the worst symptoms of opioid recovery. When you recover from opioid addiction, you tend to go through like a flu-like phase of a couple weeks or months with body aches, chills, fever. It really is rough. Once you get through it, it's better. And so they'll take benzodiazepines to alleviate some of these symptoms. The risk with benzos, though, is that they're actually addictive. And so they can be really risky when combining with opioids as well.
So I see the motivation. It's individuals who really want to break this addiction. So that's the motivation.
Yeah, which is also interesting because it's not people who are going on to abuse substances for what you would sort of consider traditional reasons, right? They're not going on and using these substances to try and get high. They're trying to break their addiction. They're trying to recover just in unconventional and sort of clinically unverified ways. And that was the most fascinating part of this, is there's this almost aspect of harm reduction, right? They're trying to not take fentanyl. They're trying to not take heroin anymore. But they replace it with something like a combination of benzodiazepines, lower grade opioids. Now you might be hooked on benzodiazepines, and when you relapse, there's a high risk for you to actually overdose because of the combination of benzodiazepines and opioids. It's like basically magnifying, my clinical collaborator likes to say it's like magnifying 3 beers into having 15 by taking the benzo. It's really risky.
So, okay, I understand. So back in the day, you would ask, how do I fix my sickness, and be like, castor oil, right? And that wouldn't have these issues, I guess, that you would have with these kind of tools or medications where you're self-medicating.
Yeah. And
then you're sharing it, like you're sharing the self-medication kind of portfolio because you're like, oh yeah, it works. So how can research help with this?
So I think research I love that you brought up the castor oil example because it's something our clinical collaborators that we did. So I worked with an addiction research scientist on this project, and he was very against considering this like castor oil because there might be evidence that this could be effective. If you think about the substitution effects, so methadone's actually an opioid. It's a lot milder than most of the opioids that people are addicted to. And the idea with methadone is you provide the substitute so that people can stay away from the riskiest kinds of substances. Kratom and other kinds of things might actually be effective. We just don't know. We've done this research. And so one of our outcomes of this is just a list of possible substances that medical researchers could start to investigate more thoroughly. Perhaps some of these are really great at alleviating some symptoms of opioid addiction. Perhaps some are really dangerous, right? Benzodiazepines in particular were one of the riskiest ones that we saw in the data set, and we don't encourage, obviously the abuse of those kinds of substances. And so for us, the interesting thing is spurring along medical research to help find these kinds of treatments that might be helpful in the future.
So it's really taking the information from the community and providing it in a curated form to the clinicians.
Yeah, in some ways. The other thing that's really interesting is the community will self-report in some cases how effective these protocols are or the risk factors. One of the posts I saw was probably 500 or 700 words about the risks of Imodium, right? And how you could actually get hooked on Imodium when you substitute it out for something else, and a cautionary tale. And so there's actually a lot of discussion within these communities about effective means, about how to dose and combine different substances, what we call like kits or stacks of medications at specific times and dosing strategies to help them recover. And so we think that this is really valuable for medical professionals who want to treat better, might know better, or have better information about what their patients are actually doing.
So I'm going to go, so the clinicians, they want to help. Mm-hmm. The patients, they want to recover. And you mentioned this stigma.
Yeah.
I want to kind of poke a little bit on that. Like, where does this come from? I mean, like a lot of people have insurance, so we're not even going to talk about that. So I have insurance. Why don't I just go seek treatment?
So the insurance question is actually something that's important to recognize. Oftentimes halfway houses and recovery techniques are not covered by insurance. And so a stay at a halfway house or completely inpatient can run some people up to $50,000. So in terms of affordability, accessing these treatments might not be affordable, especially for people who don't have really robust insurance coverage. But thinking a little more broadly about why, even if you have insurance coverage, why you wouldn't. There's a ton of shame associated with being an addict and having to admit to your job, to your friends, to your family that you're hooked on something, especially because your addiction almost always impacts them by your spending habits, risky behaviors like intravenous drug use, methods of acquiring can be dangerous. And so there's a ton of shame associated with addiction that a lot of people call them like dope addicts or junkies or, yeah, that guy's tweaking out on the street. A lot of shame exists within society. And so people may not admit the fact that they're actually addicted and seek the help that they need. And
so because then there's a fear that even if they do go through recovery, they'll still have that stigma associated with them.
Exactly. And recovery isn't, a stroll through the park. It actually is really difficult. You run the risk of you're probably going to relapse a couple times. And so the risk is you relapse, you embarrass yourself, you waste money, you set your family up for a really difficult road of recovery and relapse and all of these complications. And a lot of people, at the point where they're addicted, they don't actually believe what they're doing is causing problems for other people. So there's also a reticence to admit that you have a problem.
So this is interesting, this aspect of using research, computing research to really possibly engage clinicians into giving them the power as well as patients, giving them the power to really kick this kind of addiction and this habit. So how did you get let me ask, because I don't want to push you, but how did you get interested in this?
So I'm actually really interested in, I would call it, quote, bad behavior in online communities. And when I came to Georgia Tech through the Human-Centered Computing Ph.D. program, I met my advisor, Moon Deshowdhury, and she was really excited about mental health. And the first time we met, we started sort of brainstorming ideas about potential intersections for our work. I was interested in computational big data methods, machine learning to understand bad behavior. And she was like, there's tons of research within mental health about undesirable mental health behaviors that people engage in. And so I got excited by this combination of sort of an applied problem domain where we could really have impacts on people's lives because clinicians are now recognizing the value that social media can have for understanding people's behaviors and possibly influencing treatment in the future.
So you said the M word, machine learning.
I did.
So machine learning applied to something that has societal value.
Yeah, I love the combination of research I do because we're able to use millions of posts from social media data, use machine learning to understand these behaviors. In the example of the opioid research, we use machine learning to identify people who are talking about recovery, not people who are talking about abusing these drugs. So we built a classification system that can pull that out of about 1.5 million or so Reddit posts. And so we use the machine learning and then we go through with our addiction research scientists and annotate examples ourselves to find those alternative treatments to traditional recovery. And it's really cool because we use these machine learning approaches with such human touches throughout the process that I think it really leverages the value of both. You get big data, you get to analyze lots of data quickly, but you really get to see some fascinating trends that excite my clinical partners.
So has there ever been, so machine learning, opioid, you're coming up with this list of types of, I guess, alternatives.
Yeah.
Kind of poking on the impact. Has there been a list before? Can I go up and look under whatever the newest search engine is today?
Google Scholar.
Right. Is there a list?
No, there's not. That's one of the things that surprised our clinical collaborators the most is we were looking for information about a list of these treatments to even start looking for in the data set. That's how the research sort of got started. We couldn't find anything. There's no grounded information about these practices that are shared between clinicians themselves. So they'll learn that people will sort of engage in what they call polysubstance use for these different behaviors or these substances, but they don't learn a list. And so this is one of the first ones that we think could be potentials for medical collaborators to start researching. It's really cool. I'm really excited.
Okay, so this is, you said, the first step.
Yeah.
Mental health. What's the big picture then with respect to mental health?
So for me, the exciting thing is being able to influence treatment strategies. Now, treatment strategies is really broad. That includes things like helping doctors understand their patients better. And in this case, this will help doctors understand patients who are in recovery by knowing what they might actually be using. I can also envision in the future, with some more research, designing interventions to help people monitor their own well-being, or potentially discuss, with a trusted person when they might really, really need assistance, sort of like just in time when they're feeling concerned or at risk of possibly relapsing. So I see a lot of potential. We don't have that yet. That's one of my research goals, is to help try and figure out how we can develop interventions.
I see a lot of potential.
I do too. I think there's a lot of opportunity to think about how we could use social media and digital technology in more nuanced ways than just saying, oh, you're trying to sell heroin or you're trying to acquire heroin on a platform. We're going to ban you and you're not going to actually be able to engage with this community. There's way more nuance to, I think, improving health and well-being, that we could start to think about how to actually intervene and make a difference in people's lives.
Wonderful. So from opioid addiction or addressing the opioid epidemic to mental health issues to really addressing the needs of society using computing-based research, I think we have full circle. And I'm hoping you continue on this research in your next career.
I hope I do too. The Human-Centered Computing Ph.D. program has been really instrumental in influencing my thinking on this. I'm a problems-focused researcher, and so I get really excited to be able to use the approaches that I've learned through human-centered thinking to solve problems with things like machine learning and AI. And so I'm really, really looking forward to seeing where this research takes me.
Good. I appreciate you being on the show.
I appreciate this is a lot of fun.
So I want to kind of summarize. I hope that you enjoyed this conversation about new research that really looks at social computing and figures out how to use what we have in our brains to really impact the world, especially with respect to mental health. We appreciate Stevie for joining the Interaction Hour and encourage you to go online to our website and social media channels to learn all about Georgia Tech's presence at the CHI Conference next week in Glasgow. You can find us online at ic.gatech.edu and on Twitter and Facebook at ic@gt. Thanks for listening.